So ladies and gentlemen, welcome. Thank you very much for your time this evening to join us for the latest in the COVID updates that Professor David Wilkinson has been very kind to help facilitate for us. So once again, just a reminder, if you'd like to ask a question of David, throughout the course of the presentation, just put it in the Q&A box, which is a little box down the middle bottom of your screen here on your Zoom software, or the top right if you're on a tablet. And at the end of David's presentation, I will go through those questions with him and try and answer them all as best we possibly can. David, can I pass over to you, please?
Thanks, Paul. Nice to see everybody. Good evening, as always. It's great to have so many people joining us. I will share my screen as usual and run through where we're up to. So here is the latest update on the number of new confirmed daily cases of COVID-19 in Australia. And as we've been saying now quite consistently, the numbers are really very small now, day to day. Just almost literally a handful of cases in the whole of Australia, new cases. And most of those are being identified in known clusters and so contacts of cases. I thought some of you may have seen this kind of a summary. Many of the major newspapers are running these. This is one I look at quite regularly. It's from the Sydney Morning Herald here in New South Wales. I quite like it. I think they've done it quite nicely. And as we move not to the end of the epidemic in Australia, but the end of this phase of the epidemic in Australia, quite obviously, I think this gives you quite a nice visual summary, if you will, of what we've all experienced together over the last 2 months. Maybe let's just spend a moment on some of the key messages. On the map of Australia here, obviously the size of the circles demonstrate the number of cases that there have been in Australia, and as we all know, a little under half of them have been in New South Wales here, the largest circle. The reasons for that, of course, again, New South Wales has the largest population in Australia, but more importantly than that, we get most of the international arrivals. And of course, we had all the cruise ships and the nightmare from the cruise ships. So that explains the numbers in New South Wales, and then relatively smaller numbers in Victoria, Queensland, and the other states and territories. So, you know, Australia now, as you can see in this panel up here, the total number of cases, the number recovered. We've done, this slide's from over the weekend, and things are changing all the time. We've now done over 1 million tests in Australia. So, you know, almost 1 in 25 people in Australia have been tested. And the point prevalence is well less than 1%, 0.7% of people testing positive. There are about 45 people in hospital in Australia, 17 in ICU. So, you know, as we all appreciate, absolutely tiny numbers. And then there's a breakdown by age, and you can all click through and go through these data as you choose to. There's a breakdown by state, and of course our epidemic curve, which shot up in April, is now well and truly down. So the next slide is a new slide for us, and I think it's quite interesting. Gives you a visual representation of the source of infection of COVID in Australia. And as you can see, since the end of March through to the present day, you know, about, 60% of all cases from overseas. They're about 25% local known, and then about 10% or so local unknown. And clearly, as you can see, those numbers are not changing very much now. The key point here for us to think about is that, you know, the epidemic in Australia basically was imported cases of travellers returning from overseas, and then there have been a small number of well-known outbreaks here in New South Wales, aged care facilities in Tasmania, the Northwest Hospitals up there near Burnie in Victoria, Cedar Meats, and of course the cruise ships, again, clusters and outbreaks, and very little now local transmission. And as we said a couple of slides ago, the numbers in Australia now are really very, very small, with most states and territories not reporting any cases now. On this slide, we've seen versions of this before. This is a selected number of cases around the world. And the key thing here, of course, is the flat lines here, the horizontal lines like China, South Korea, Australia, New Zealand, Taiwan. All of this means that there is no growth in cases, no more growth. Remember, we have a log scale here. So for example, the difference between South Korea here and China here is 10 times the number of cases. So about 10,000 in South Korea, 100,000 in China. It's interesting, you can see here that Italy is going flat now. The UK is starting to flatten. The US is still on an upward trajectory. So in many, many countries around the world now, the epidemic is either over in terms of no growth or starting to settle in terms of no growth. But it's not true in all countries. The US particularly is a problem. I thought it might be useful to reflect on some of the key stuff that's going on in the media here at the moment, and some of you will have been following this and be conscious of the discussions that are underway about the emerging reality. Seems to be that most of the epidemiological models that were developed to help us think about the COVID epidemic and how to respond to it are actually wrong. Now, that's a bold statement for somebody like me to make, but there is an interesting editorial in the New England Journal of Medicine this week, and the link is here. And as you can see, the title is Wrong But Useful: What COVID-19 Epidemiological Models Can and Cannot Tell Us. It's going to be interesting to see how all of this washes up and plays out. But it is very clear that many of these models had a whole series of flawed assumptions in them, and some of them were quite badly designed. And what was predicted has actually not come to pass in the models. And so there's quite an interesting issue there. It's relevant because I think it helps us think about how we come out of the lockdowns, and how we think about whether there might be second waves or not. So it's important to sort of be thoughtful about this, I think. There was a very amusing, I thought, cartoon in The Australian last week. A group of folks here queuing up outside Centrelink, and there's an unemployed chef saying, "I thought you'd be flat out to death." And Death is saying, "So did I. That'll teach me to trust the modelling." Gives you a sense of the perspective that at least some people are reflecting on at the moment. And of course, now this moves us into where we are with the economic fallout of the shutdown. And I was startled by this graph from the ABS. It was published in the Australian, I think, which shows you the change in monthly employment for March of this year. And it compares it to previous months all the way back to 1978. And you can see the blue line here jiggling around, as obviously employment varies over time, and in the recession and the dot-com bust and the GFC, you know, things get a little bit bad. There has never been anything like the complete shutdown and the loss of something like 500,600,000 jobs in Australia in 1 month. Absolutely cataclysmic. And of course, this is the situation now. And these, of course, are people who signed up as unemployed, and it makes no consideration for people on JobKeeper. There are some estimates from people who know about these things that unemployment in Australia at the moment is about 20%, and the US is looking at about 25% at the moment. I mean, this is utterly catastrophic, and of course, is the focus now of turning this around is the focus of government. We showed last week, of course, the new 3-step framework for a COVID-safe Australia. It's worth reminding us ourselves about this. Most states and territories are now into or getting through step 1. Just this evening, New South Wales have announced that all schools will go back full-time on Monday of next week. Massive relief to many parents, and a very important step forward, I think, in terms of getting New South Wales moving again. But still a long way to go with step 1, step 2, and step 3 to really open the economy up. And some of you will have seen this just today, that the premiers of Queensland, South Australia, WA, and Tasmania all making it pretty clear they have no intention of opening their state borders anytime soon, which is interesting because without tourism, Australia's economy is not going to get going. I would bring up this COVID-safe business planning tool, which the National COVID Coordination Commission has brought out. I think this is really good, and we're working on this at the moment for our clinics. Everything, the whole narrative at the moment is around COVID-safe everything, COVID-safe workplaces, COVID-safe public transport, etc., etc. And we all need to get onto that narrative and that story. And I would point you all in this direction if you have responsibilities along those lines. And if we then flick into the clinical situation, in the peer-reviewed, high-quality medical press, which should be our primary source of information. Again, this weekend in the New England Journal of Medicine, there's a really interesting case, a severe COVID-19 case, which you can go through for a sort of professional development perspective. And it's quite interesting how they sum up in the key clinical points. Now, all of us on this call are not responsible for looking after patients with severe COVID, but those of us with an interest in all of this, it's well worth having a look through this case and understanding getting an appreciation of the level of understanding that the critical care clinicians are working on. The bottom line at the moment is, in terms of managing these patients, it's critical care and ventilation, and nothing else works. That's where we are. So at this stage of the epidemic, there's no good evidence that anything is changing the course and the natural history of COVID, other than intensive care and ventilation. There's a lot of research needs to be done. There's a long way to go with all the trials that are underway. It's going to be very, very interesting to see how that plays out. So just to bring this to an end, I attended a very interesting webinar last week with the New South Wales Treasurer. Dominic Perrottet was on there, and he talked very cogently actually about the way government is thinking about this is 3 phases: response, recovery, and reform. Response, they feel, is done. The health response is done. New South Wales has tripled its ICU and ventilation capacity. Looks like we're just not going to need it, like the rest of Australia. Fingers crossed for that. But government now feels the health response is done. Their absolute priority now is recovery, and that is economic recovery, but also social and societal recovery. Get the economy moving again, get people out and about, back to work and socializing again. And then very interestingly, they're now talking about what reform, industrial reform, HR reform, et cetera, can occur So it's going to be very, very interesting to see how all that plays out. At the more local level, I think there's a really interesting opportunity for all of us, you know, with skin cancer clinics, is to think about what's a COVID-safe clinic. You know, if COVID goes away, all well and good, but I don't think anybody sees that happening. I think we're going to learn to live with COVID. You know, as people start moving around again, everybody's expecting outbreaks. Once we open the borders again, we've got to open the borders at some stage. So thinking about a COVID-safe clinic, COVID-safe workplace from the perspective of staff and patients. And certainly the way we're thinking about that where I work is, you know, the workplace needs to be safe. We all need to be able to trust each other, that we won't come to work when we're sick, and that we'll adopt the appropriate protocols when we're at work. And then everybody has to have control of their own situation. So everybody will have to have, you know, individual responsibility and not rely on the boss or the manager or whatever it is. And I think fleshing all of that out at a clinic level for the going forward is really important. You know, what does that mean? Well, most of it's dead simple, right? From now on, nobody ever comes to work if they're sick. It's as simple as that. You don't soldier on, you don't push through, you don't work with a sniffle. Just doesn't happen. It's not acceptable. No patients seen in a skin cancer clinic if they have respiratory tract infections. You know, very strict hygiene in the clinic, appropriate social or physical distancing, whatever you want to call it. Waiting rooms, distance from staff, and so on. The possibility of special clinic sessions for vulnerable patients, right? Could be a competitive advantage, could be something that elderly and sick people would really appreciate, and that staff in the clinic might appreciate. So that's something to think about. And I think at some level, we all have to accept that outbreaks will occur in the future. As I say, I think we're moving into a phase where we live with COVID at some level. We have to recognize that. We kind of have to accept that, recognize a risk level, and adjust to all of that. So I'll leave that there. Paul?
Awesome. All right. Thank you, David. I'll get you to stop unsharing your screen. That'll be awesome. So I've got a few questions for you. I've got 6 to be precise. So let's start with those. But just a reminder, if you do want to ask a question of David, there's a Q&A box at the bottom. Just click on that, type in your question, and I'll answer it. Well, sorry, pass it on to David to answer. I won't be able to answer too many, I'm sure. So some of them probably comments or questions. So will the continuation of telehealth be beyond September? I mean, do you think this will be supported by government? And what are your thoughts on, you know, I suppose the limited item numbers we've got till now?
Look, I think it's very difficult. It's going to be very difficult for them, for government to shut telehealth down. What I'm hearing on my circuits is that they're very pleased so far with aspects of the way that's gone. They feel that they're a bit surprised and a bit disappointed that it's almost all phone and very little video. So I think there's an opportunity perhaps for us in skin cancer to do something there. The word at the moment is there's very little abuse, although some, of course, as always. And I think there's that for those practices that can demonstrate a really authentic model of telehealth being fully integrated into patient care, I think it'll continue. What I would say, and I'm not telling any tales here, is that Professor Michael Kidd, one of the Deputy Chief Medical Officers, is a massive fan of telehealth. He's pushed this through, basically. And I know Michael well. He was Dean of Medicine at Flinders University while I was at UQ. He will want this to continue, and I think there's a real opportunity there.
Yeah, and I think also bear in mind, until there is, well, vulnerable populations, you know, can come out and be freely available. I mean, they don't really have a choice but to still have some level of service provision. I think, as I said, the genie's out of the bottle. I mean, I know for our practices, we've modified some of our software so patients can upload high quality images through a piece of software, so then we can, you know, provide a consultation. As you know, in skin cancer, video consultations are not that very useful in diagnosing a lesion. All right, next question is, with cruise ships now seeking bookings, what changes will there need to be from a safety perspective? And And will travel on a cruise ship contravene international travel restrictions?
Yeah, it's interesting, isn't it? And again, one of the other deputy chief medical officers was talking about this over the weekend. And I think the line basically was, cruise ships are the very last thing we're ever going to think about. I mean, clearly, very high risk environment. Lots of people in a confined space, elderly, often comorbid, world famous for outbreaks anyway. A petri dish for coronavirus. I mean, it's going to be a nightmare, and I think there's a long way to go before the cruise industry gets back on its feet. And New South Wales made a mess of the Ruby Princess. I mean, that's obvious. And although at some stage in the future cruise ships will be back in Sydney Harbour, I reckon it's going to be a long period of time. I think the quarantining of all returning Australians is going to go on for quite some time, and that's their core mechanism. But I don't see the cruise industry going anytime soon.
Sort of interesting. I noticed with Singapore Airlines, obviously I fly out of there, the buffet meals gone. They're just going to be basically, even when you go to lounges, there's no such thing as buffet food anymore because of obviously potential risk of transmission. So cruise ships obviously rely on quite a lot of that. Next one is, what do you make apparently of the low death rate in Russia?
Well, I think number one, not sure how much you can trust the data. I don't think they tell the truth about very much with respect in Russia at official levels. You think about shooting down airliners and invading neighboring countries and et cetera, et cetera. So, a bit of a shrug of the shoulders. It looks good, doesn't it? If you say, well, lots of cases, nobody's dying, you can sort of, spin a good story. So that would be my primary thinking there. The second point is that, it may be relatively early in their epidemic and all the deaths are coming, but whether they'll count them and then declare them is another matter. So I think it's a data thing.
Yeah. I think it's one of the troubles with probably certain countries, and probably US and China we put in that category as well. I think it's very highly politicized as to what those numbers are. I mean, obviously Trump's sort of trying to say, no, the numbers are incorrect. They obviously play that down because obviously coming into election, that's what he would want to be saying. So I think it's going to be unfortunate.
Yeah, no, I agree. And it's very well worth just making the point to people that you would think that it's easy to count deaths from COVID. And it's just not. I mean, it's easy to count deaths, but most of the deaths reported in the UK as COVID deaths have not had a COVID test. So, we've got to take these numbers not with a pinch of salt. That would be wrong. But these are not accurate, as in, and even one country has a different definition to another country. And there are delays and so on and so forth. So when you look at this in some detail, the numbers are certainly wrong. They're not accurate. And they are probably in countries like the UK and the US of A, they are probably underestimates. And it'll take months for all of this to really wash out. What is going to be really interesting is to see the number of excess deaths that occurred in a particular calendar period, and that will give us a good sense of how much of this was COVID related. So people just need to take the absolute numbers with some caution. That's not the case in Australia. We've got so few cases; they're all tested. We know that those people died with COVID, and we assume that COVID killed them, if you like. But lots of people are dying, and the COVID is incidental. Lots of deaths are being certified without a COVID test, but they are fulfilling the epidemiological criteria. Yeah.
And there's also obviously people who didn't present for other reasons because of that particular issue that obviously have passed as a result. I know that in Sweden they're trying to work out the numbers based on that as well. So that's how it's interesting. The New York Times had a great article on that last week. Okay, next question. With regards to modelling then, does it not follow that as Australia tries to lift restrictions, having placed the population in lockdowns, without vaccine immunity or herd immunity, the risk factors are there for a possible second wave, but there's larger numbers of positive cases and potentially more stress on our healthcare system?
Yeah, I mean that's exactly right. That question from Francis. So the bottom line with the modelling is, and again, this is not being critical of individuals or particular universities or particular methodologies, but all models are models, and they make a whole series of assumptions. The problem seems to be that the model from Imperial College and Professor Neil Ferguson is now being pretty roundly discredited by almost everybody. And it seems that this group that did this modeling has a track record of getting this stuff wrong. And it was their modeling that dictated the UK approach and has been highly influential around the world. I think, Francis and colleagues, what we're seeing now is that we're going to have so much real world data that we are not going to have to rely on the models. And so that's a good thing. So in terms of where this leaves us for second waves and so on, my bet is that with the social physical distancing, the personal hygiene, the not going to work while sick, my bet is that will be enough to limit the risk of a kind of so-called big second wave. My bet is there will be outbreaks, aged care facilities, maybe in hospitals when infection control breaks down, cruise ships, other settings where a small number of people are all gathered up together. You know, there will be outbreaks. And this is, of course, what the authorities are terrified of. You know, I mean, Francis is right. I mean, there is no vaccine. There's certainly no herd immunity at the moment. It'll be interesting to see if there is herd immunity in the UK. There's some work that suggests that there may be in London, but we just don't know. Nobody knows, and time will tell. And the point I think here is that for me, we've moved out of this phase of the epidemic, and we are now all going to move forward. And certainly in Australia, that we know that the levels of infection are incredibly low. And if we maintain an appropriate level of social distancing, hygiene, and testing and contact tracing, then we can be confident that there won't be a second wave. But that's exactly the issue that we face. So while it's going to be very quiet, I think, for quite a few weeks and months now, it's going to be watch this space very, very closely. I think that sums up the situation.
Excellent. So next one, you may be able to help with or not. I might be able to help more so. So with telehealth, do you think the bulk billing only prerogative will change for the better? I rebate to patients if free charge. So I assume this is the vulnerable, like, you know, the people that we have to bulk bill as such.
I mean, you may have a view as well, Paul. My bet is that it will become much more aligned with you know, normal billing practices over time. Yeah. They've got to start somewhere and then ease it up, don't you think?
Yeah, I agree. I don't think they're going to try and change it because it would just obviously increase the cost of anyway. But, you know, we can privately charge for telehealth consultation as long as you're not in a vulnerable, you know, concession card / you know, under 16 sort of grouping anyway, which for a lot of practices, once again, depending on who you see as your patients, so there's going to be a small or large number, but ultimately it's providing services to people that wouldn't come otherwise. I don't know, from our perspective, I mean, if someone's going to take a photograph and contact us about something they're really concerned about, we're pretty sure that they're probably going to come in and see us and obviously get it checked out. So two other questions that I had actually is, With the state borders, so it's interesting obviously to see, you know, Palaszczuk today with regards to Queensland saying we're not going to open the borders potentially up until September because of local healthcare advice, even though the federal government's pretty much obviously pushing for opening the borders in July. There's obviously pushback from South Australia and other states that would indicate, now, is it because they are that scared of Victoria and New South Wales? I mean, because obviously part of the conversation with the Queensland Premier is maybe with South Australia, WA, you know, we'll have your citizens or come and join us. So I was just wondering what state-based information have they got that obviously the federal government is not paying attention to in that situation?
Well, my bet, and I was talking to a couple of key people offline in New South Wales Health about this today, because I find it really perplexing. The position from the federal chief medical officer is exactly as you outline it, Paul, which is we've smashed this. The levels are incredibly low. We need to open the economy and society back up. We have to accept that there will be cases, there will be outbreaks, but we have a very strong public health system now. We're testing like mad. People will come forward. They can get tested. We can control any outbreaks. We've got to get going. The word on the street, and you know, I say that very senior street, if you like, is that what we're seeing, and I think we saw it today, Paul, in the language used by some of the premiers with respect, and one of them is your good friend, I know, and his language was very moderate, and I thought, is that this is now politics. Yeah. And that not one of them can face the thought that cases might go back up and that they are premier over some deaths. The problem with this is, where do you go, right? If the goal is zero, and zero for how long? Because if it's zero for a day, make it zero forever. Well, you know, there's no future for Tasmania, there's no future for South Australia, probably no future for WA with closed borders. No future for the rest of us. So, you know, I think we're seeing a return to the bad old days of politics and state-based politics. You know, pretty nasty language today, very unhelpful. You know, when unemployment is 20% and when JobKeeper finishes in September, unless the economy's back up, you know, we're stuffed. So pretty disappointing, I thought.
Got to make a phone call. All right, the next one for me is just some stuff that's coming out of the States, obviously with this COVID syndrome with children in the US. I mean, it's obviously just emerging. Have you read anything about it? Do we know anything much about it? I mean, obviously it's, numbers here have been so small, it obviously hasn't probably presented, but on the country that's got 1 million+ cases, then, I mean, it's only a small pocket, but I'm just wondering if you know much about what that is.
Yeah, well, I'm reading what everybody else is reading, and there is this, clearly there is some form of inflammatory syndrome, and in a way that's no surprise, because we know that the severe COVID disease is an inflammatory reaction to the virus. It's not the virus itself. So this Kawasaki syndrome, or Kawasaki-like syndrome, or whatever you want to call it, you know, it looks like it does exist. It looks like it's really, really rare. And, you know, again, in Australia, we don't have any cases. We don't have any COVID cases now. There's like a handful of people on ventilators in New South Wales. So, you know, I think it's clinically really interesting. And, you know, the number of the full description of the COVID syndrome itself is still emerging, that all of this kind of stuff, you know, is going to emerge over time.
Yeah, awesome. And just last one is probably a comment before we close, which is from Andrew, and I thank you for this. This is actually the message we've been pushing out to our patients and to the wider community around the fact that melanoma mortality rate 7 times that of COVID in Australia, and I think you probably find it's actually probably in higher. It's, you know, one of those things, you're more likely to die of skin cancer than you are obviously COVID, and you know, some of that message, but it's not just that, it's obviously all the other preventable things. And I'm hoping that once again, seeing your practices get back to normal. I know with our 9 practices, we are back to where we were basically in February, as far as patient numbers and all of that sort of stuff is concerned. We've been disrupted for 2 months, but we've come out the other side of it. Now, I'd like to personally thank David very, very much for your time, once again, for your contributions. Just having spoken to David prior to this call, we sort of believe that, I think as far as the emergency part of it is pretty much dealt with. I think that We can see a pathway out with relation to government and policy, and as I said, it's now into politics, not into medical science as a decision-making process. So what we basically agreed is if something comes up that is of significance, we're going to organise to hold another one of these webinars. But I think just as far as the daily updates is, so the numbers are quite small. We've really got it under control. And as I said, if something does come up of significance, we'll communicate with everybody and then organise a webinar, but we probably will leave it as the last one that we'll do as a weekly activity. But I really do want to thank, firstly, all of you, because there's so many familiar faces in obviously the attendee list, and I hope you found it a benefit. It's obviously been a pleasure to help coordinate it, and obviously thank David very, very much for obviously taking the time and effort to help facilitate this process for it. As I said, it's not over, and if something does come to the fray that we need to be aware of, we'll make sure we get that straight out to you as soon as we possibly can. So David, can I thank you very much for your time? And just a quick reminder, on Thursday, as part of our series, we've got an interesting group of lectures, or a lecture on. So basically we're looking at, with professional development, now we're coming out the other side of it. We've got a Q&A session with our EA team. So talking around study options, etc. So it's actually a live interactive Q&A session, which is something we've not run before. So if you are obviously interested in the different pathways, and also this is at 7 o'clock on Thursday, and we actually have got some new pathways coming out. So we've got a women's health pathway about to be released, medicinal cannabis, which will be in August, and men's health, which is a little bit later in the year. So we're going to be actually rolling out some additional programs which might be of use to you as well. Anyway, enough of that. Thank you so much for all your time. I hope you have a wonderful week and look forward to speaking to you very soon.